I would welcome all of you to this session here. Start with, and we'll ignite the spark with Dr. Mohan Keshavamurthy.
It's a huge pleasure to be here. I grew up in Vijayanagar most of my childhood. It's always a pleasure to come back to where it all started. I have the privilege of leading the largest urology team in private practice in the country. And Dr. Prem is one of the first commanders we had almost 15 years ago when we started small in the central part of the city. As we have grown and as equipment has come in courtesy Fortis hospitals, we have been able to build a 360-degree urology practice encompassing every new advance that is available in the world and made it locally available. Also the fact that it has to be at a reasonable cost with excellent outcomes or excellent world-class outcomes. North part of Bangalore is growing quick. We would anticipate Fortis Nagarbhavi to double its bed strength, as well as the possibility of bringing in a robot between now and 2026 Diwali. With that in place, the topic I wanted to discuss today, we have a nascent transplant program at Nagarbhavi. So I wanted to discuss what is it that we can do in the area of kidney transplant, specifically at Fortis Nagarbhavi. So this is a highlight I wanted to put across. We are a large program. Fortis Nagarbhavi is one part of this large program. We are also a 3-seat DNB program, and we have virtually a training program for every aspect of urology based out of either Bannerghatta, Cunningham or Nagarbhavi. We have every piece of equipment that money can buy. I can go as far as saying we are as well equipped as Cleveland Clinic in the US, which is considered the Mecca for urology. Coming specifically to the topic, whom can you transplant, whom you cannot transplant in modern day urology. When I did urology 30 years ago in KEM Mumbai, the rule was, or we used to write a short note, that diabetic nephropathy is a contraindication for kidney transplant because of microvascular disease. But if you look at kidney transplantation in India today, two out of 3 patients, the basic disease is diabetic nephropathy. So there is a paradigm shift of who can be transplanted. In the same way, we transplant retropositive patients. We transplant a second time, a third time, a fourth time, a fifth time. I have transplanted an Iraqi Olympic footballer for the 5th time. We also transplant patients who are Hep B, Hep C positive. We also transplant pediatric patients, anybody more than 10 kgs in weight. We transplanted a 63-year-old grandmother's kidney to a 4-year-old boy 2.5 weeks ago. We also transplant patients who have a neurogenic bladder. It's an area of immense interest for us. We are one of the only centers in the country capable of managing a kidney failure patient with a neurogenic bladder, typically pediatric patients who are well looked after with a PU valve syndrome or with a congenital anomaly and reached adulthood. We can also transplant patients post PTCA and CABG. This is a large cohort of patients. And we also transplant patients who have had a malignancy which has been successfully treated. And those patients who receive a liver or a heart transplant, more liver than kidney in India right now, because of the calcineurin inhibition, whether it be cyclosporin or tacrolimus, 1 in 3 will need a kidney transplant if the graft, either the heart or the liver, functions beyond 7 years. So these are the scenarios which were difficult a decade ago, but the quality of immunosuppression locally available because of generics and the ability to adapt technical skill to the specific requirement of the patient allows us to provide an excellent outcome irrespective of the complexity of the recipient. The donor factors were also an important part. One of the things for a major network in Bangalore would be that any person with a BMI of more than 32 could not be a donor. The average BMI of the donors we do in our program in the last 2 years is about 35. One of the reasons is they're refused elsewhere, they do turn up with us. The other fact is if the only donor available, living related donor available, happens to have can only donate a right kidney because the left kidney is far better functioning, and we obviously leave the better kidney for the donor and take the less better kidney for the recipient. Or if both the kidneys have multiple renal arteries, or the the donor has undergone previous surgery. For example, a female donor who has undergone multiple cesarean sections or has undergone hysterectomy. All these scenarios, possibly in the previous decade, were contraindications as for donation. And again, these are the patients we would prefer to operate today at across Fortis Hospital's transplant program. So irrespective of the recipient difficulty or the donor difficulty, in terms of anatomy or physiology, we are able to overcome with technique and expertise to give them the same quality of outcome as it would be in a straightforward living-related kidney transplant. Coming to a sensitized transplant, Dr. Manjuna Sakana will throw more light on it. Whether it be ABO incompatible or patients who need a second, third or a fourth transplant, there will be preformed antibodies, and he would discuss how do we clinically manage such patients. The technique for the surgery remains the same. When it is a redo transplant, where do you locate the transplant? So there will be 2 native kidneys, there will be a third and a fourth kidney, possibly we have to plug in a fifth kidney. Finding appropriate vascular channels to plug in the kidney is a challenge, as well as the problem of preformed antibodies, providing the possibility of greater rejection in these patients. Seropositive, retropositive patients, if they are CD8, CD4 reversed and they are free from retrovirus, because of independent HIV-mediated mechanism of glomerulonephritis, 1 in 7 patients to about 1 in 5 patients will reach renal failure within 7 years from the initial diagnosis of HIV. And these patients are a major cohort of patients who will require kidney transplant. In the United States, UNOS now has a separate category of deceased donors who are HIV positive or retropositive for patients who need kidney transplant. We don't have such a facility still in our country, but this is an important cohort of patients we treat. We are a major center in Asia for treating retropositive renal failure with kidney transplant. Again, Hep B, Hep C is an area of interest for Dr. Manjuna Sakana. I would let him discuss that. This is an area of interest for us. 1 in 3 patients who undergoes kidney transplant would have had a cardiac event either as a part of the renal failure process or preceding it. And this was a major contraindication because anticoagulation could not be stopped. Today, we are able to transplant the patient either using cansegrelor infusion, which is a short-term infusion to provide anticoagulation for those who have undergone a stent in the previous 6 months, and there is no way you can stop the antiplatelet, versus using a technique of bare metal stent if in the course of the workup of the transplant, it is found that the patient had silent asymptomatic coronary artery disease but needs to be corrected prior to transplant. Also, the fact that intraoperative monitoring with transesophageal echocardiography is freely available allows us to monitor those patients with ejection fraction below 30%, which was again a contraindication for doing renal transplant surgery, especially in the era of robotic surgery, where we are one of the 3 centers in the country performing large volume robot-enabled kidney transplants. Providing a steep Trendelenburg with low ejection fraction is a contraindication, but with intraop TE monitoring, it has become safe to perform kidney transplant on such patients. The last is the manipulation and anticoagulation. We do not stop anticoagulation during kidney transplant. In fact, we restart anticoagulation on the day of transplant. So post-PTCA, post-CABG patients can be taken up within 6 weeks after either, depending on the emergent situation of needing a transplant. Neurogenic bladder is the area of interest. Typically, they are PU valve neglected or inappropriately treated patients who end up with early renal failure in the pediatric age group but continue into adulthood needing a correction of the neurogenic bladder. We use a variety of techniques including Mitrofanov, that can be a topic for discussion later today, or reconstructing the anatomy of the bladder, ureter and the kidneys prior to performing a kidney transplant. There was a moratorium that you don't transplant patients with successfully treated cancer irrespective of the organ for 24 months. That remains, but for cancer of the kidney, that can come down to as low as 6 months after successful treatment if the histopathology of the cancer kidney is low grade and is a clear cell carcinoma. So as far as difficult donor, we are one of the few centers in Asia to use 2 twin robots to do both donor and recipient is synchronously using the robot for kidney transplant. But even at Nagarbhavi, we have the technical ability to use 3D laparoscopy, which is equivalent or the nearest equivalent to robotic surgery, to be able to harvest right donor kidney or with a vena cava cuff or kidneys with multiple arteries, and then reconstruct on the bench either as a pantaloon or as independent vessels for multiple arterial anastomosis transplant. Again, something we can discuss if any of you are interested to learn more. Donor optimization, if the BMI is beyond 38, then we would need the patient to lose weight prior to performing donation for kidney transplant. This is a brief video of a robotic transplant surgery, or even if you have seen, you will feel that you will also be able to do the transplant after the short video that I'm playing. It makes the Da Vinci robot makes vascular surgery far more easier. Although I was a reluctant convert to do a robot-enabled kidney transplant, we do 90% of our transplants today robotically enabled. So we prepare the external iliac artery and vein, and then prepare the bladder to receive the ureter. Once that is done, then in the parallel OT, a colleague of mine would be doing either a laparoscopic or a robotic donor nephrectomy. This is preparing the bladder to receive the ureter. And once the bed, as we call, is ready, we use an improvised hand port to drop the kidney into the abdomen. It is wrapped in gauze so that we can move the kidney around without injuring the kidney. And then we use robotic bulldogs, expensive toys, to block the external iliac vein for a start. And we make a venotomy, and we use a special suture called gore, where the suture has the same diameter as the needle, so the needle hole won't bleed, which is what happens with the more common vascular suture, which is Prolene. So the white suture you're seeing is called gore or Gore-Tex suture. And then the advantage of doing it robotically is you can see both the entry and the exit of the needle in the same sitting, like those who have seen a finger sewing machine. So unlike the human eye, which has binocular vision using both eyes, the robot has two binocular visions. So there's a right binocular vision and left binocular vision. That gives you the ability, and the first assistant would be seeing what exactly is going on. So depending on the mood of the surgeon and the music playing in the room, the rest of the team would know whether the anastomosis is going well or not. Here it is seen on 7 screens in the robotic OT, so everybody knows how well is the transplant progressing. So once the renal vein is done, we put a bulldog clamp across the renal vein and start the anastomosis of the renal artery. In this case, is the external iliac artery. And we use an improvised Indian arterial punch because Da Vinci robot doesn't have an arterial punch so far. Typically, robotic transplant is an Indian innovation. It's called the Medanta technique, after Dr. Rajesh Ahlawat, Indian urologist who devised this technique almost 15 years ago. And again, we then suture the artery to the external iliac artery. The ability of the wristed instrument, which is unlike laparoscopy, allows a more precise approximation of vascular structures or for reconstruction anywhere else in the human body. And this allows us to take care of vascular difficulty, whether it is multiple arteries, whether it is a right-sided donor kidney with a short renal vein, or it is a third or a fourth transplant needing me to put the kidney on the aorta and the cava directly. The precision and manual dexterity of the robot, along with twin binocular vision and the fact that it filters tremors of the surgeon. Usually a senior surgeon like me has the anatomical knowledge and skill, but you develop tremors, subtle tremors. The robot filters tremors and only effective movement is conveyed into the operative field. Here we are declamping it, and as you see, the kidney picks up immediately and the gauze jacket is taken off. The kidney is placed lateral to the medial to the vessels and then flipped over to take the position as in open surgery onto the psoas. Then the ureteric anastomosis is done. So this was just a brief glimpse to show that we have evolved to do even robotic surgery, even kidney transplant surgery robotically. I will not play this, so we can do even double artery with as small renal arteries as 3 millimeters, which is same as the coronaries, and do it effectively. I will jump this video, and this is the size of the team I'm privileged to lead. One of the reasons I'm not the best, but I'm the oldest, so I get the privilege of talking first in these CMEs. So it's a team effort that allows us to provide pristine outcomes. Even as we talk here, I have 2 of my colleagues operating across the world. So a large team, not just of doctors, of techs, nurses, committed personnel, allow us to provide world-class outcomes at reasonable cost in every location where Fortis Hospital allows us to practice. It's a privilege to be here today. That's the size of the team. Everyone there has the same degree as I have, either a MCH or a DNB in urology. Thank you for your patient listening. This is last year's Karnataka government's recognition for the service that we have brought to the city in terms of innovation in urology and kidney transplant. Thank you.